retinopexy. So it's really a matter of very common principles. It's a simple technique, but attention to detail is key. And it all starts with a detailed dilated fundal examination with an indirect ophthalmoscope and scleral indentation. Pay attention to landmarks as you do the examination, not just any breaks, because you want to identify any lesions which require pre-treatment, but also those landmarks may come in handy when you come to laser the retina with gas in situ later on. One can consider marking laser at the aura preoperative if you're worried you have a small break that you may struggle to see, subsequent with the gas in situ. So just the preoperative examination and attention to detail, I can't overestimate the importance of that. Anesthesia. We prefer topical anesthesia with subconjunctival anesthesia than a peribulbar block, for example, or subtenons. That ocular motility is very helpful in terms of ocular positioning during the procedure, and also feedback once you've injected the gas in terms of the optic nerve perfusion. Of course, we sterilize the eye with povidone iodine, a lid speculum and a drape. Certainly in the UK, that would be mandatory. You can proceed with your retinopexy in two ways. You can either use cryotherapy before injecting the gas, or laser once the retina is reattached a day or two after gas injection. So the advantage of cryotherapy, it's convenient, it's one step. It's also helpful sometimes because it can help you confirm the presence of a break when you see the cryoreaction coming up immediately on the table. The disadvantage is that the adhesion is a little bit slower. In large breaks, you can get an exodus of pigment cells through the break. And there is, of course, the potential for ocular inflammation and discomfort with extensive application. So the indication would be small or hard to find break, where there is some local media opacity, that means you can't get laser uptake. Certain situations are very pale fundus. Again, it's really hard to get laser uptake. You'll be aware of that in your clinical practice. And in aphakia. So if you're going to put a bubble in an aphakic eye, when they're supine, it can be very, very hard to see what's going on. The advantage of laser, you have immediate degree of chorioretinal adhesion. The disadvantage is naturally it's two-step. You have to wait 24, 48 hours for the break to reattach before you can apply the laser. And visualizing the retina through gas, it's absolutely possible, but there is a learning curve. You need to be good at indirect ophthalmoscopy without gas in situ, and then the learning curve is shorter with gas in situ. And the indications would be, well, probably the majority of pneumatic retinopexies, but certainly the large, extensive posterior breaks that are very bullous, or, for example, a tear overlying a scleral buckle. This is a rare situation, but occasionally you can rescue a buckle with a pneumatic. Cryo wouldn't be possible in that situation. As Peter alluded to, AC paracentesis, it sounds simple. It is simple, but we need to harvest the aqueous, a large volume of aqueous as possible, to facilitate the injection of a large gas tamponade, because that directly correlates with your likelihood of tamponading the breaks and surgical success. So we need a 30-gauge needle, a 1 ml syringe. You put the needle on the temporal side, and you use the plunger on the nasal side. The needle bevel is orientated anteriorly in phakic eyes, as you see here. We take an oblique passage over iris tissue. In pseudophakics, you can just go in radially and hold the optic back. It's very easy in that regard. You need a firm, constant pressure with the plunger so that you have a dome of cornea, creating some depth for your needle. And the aim is to flatten the anterior chamber. You take as much as you can, and generally at least 0.3 mLs. It's not uncommon to see Schlieren from the posterior segment coming into the anterior chamber, a flat anterior chamber, and a few red cells after the anterior chamber paracentesis is absolutely no concern. Having seen thousands of eyes in this situation, I guarantee that they will be gone by the next day. You want a flat anterior chamber. So what you can see here is a case of mine. My needle is temporally. I hold the needle very, very gently in my hand. You can see how, as the anterior chamber is flattening, so this is a young, phakic person with a beautiful clear lens. I'm taking great care to go over the iris. You can see as the AC flattens, the needle is just sort of falling, if you like, and the tip is rising with the iris, so I'm not traumatizing the tissue. And we've flattened the anterior chamber and harvested, more aqueous than you would expect. Rajiv, well, I'll talk about gas injection. We switch, sorry. Yeah. So in terms of preparation of gas, so we use 100% SF6. It expands quickly, okay? Even if you have a couple of bubbles at the time of injection, they tend to coalesce very, very quickly. And then they resolve quickly. So the patient has a bubble in situ for 12 days or so. It's very, very important to use undiluted gas. So whatever kind of cylinder or syringe you're retrieving the gas from, you need to flush it 2 or 3 times because you want maximum expansion. And then you attach a 30-gauge needle to the syringe, and then you rest it tip up until you're ready to use it. And try and use it within a few minutes. As I say, you want to maximize the expansion. In terms of gas injection, we want to inject away from any large open breaks, 3.5 to 4 millimeters from the limbus, and the aim is to achieve a single bubble. And the way you do this is by injecting into the highest point of the eye, hence ocular motility is helpful. Your syringe needs to be vertical. As you inject, you need to penetrate the vitreous body and then retract until you're about 1 millimeter into the eye. And then the injection has to be swift and steady, not hurried, not stoppy starting, okay? And you're aiming to put 0.3 mLs more gas than you harvested, okay? Really, the least you can get away with is probably 0.5 mLs. Any less than that, you end up with a round round bubble instead of a flat-bottomed bubble, which doesn't tamponade so well. And then you immediately place a cotton bud on the track so there's no egress of the gas. You then have to check the optic nerve perfusion, and we're going to just splice over to Rajiv.
Yeah. Okay, so once the gas is in, now you got to make sure that the intraocular pressure is okay. So you want to check the central retinal artery perfusion. And often, if you've put in 0.6 or more, you will have to, or in my practice, I will do a second anterior chamber paracentesis just to have the central retinal artery pulsatile. The patient can see hand movements, and then you can discharge the patient. It's very important to stress positioning to the patient and the family and the importance of compliance in order to achieve good outcomes. And I explain to each patient exactly how I want them to do the steamroll, how I want them to position. And the steamroller maneuver is very important because by initial face down and gradually raising the head, you can express a lot of fluid through the retinal break, reducing the amount of work that the RPE pump has to do. And therefore, by the next day, many times the retina is fully attached. Indirect laser, as Roxanne said, there is a steep learning curve, but once you do about 20, 30 cases, it becomes fairly straightforward. It's important to do certain things. We've talked about marking the aura in the meridian of the break, very careful drawing so that you know exactly where the break is. And subconjunctival anesthesia can be helpful, particularly if you have breaks that are at 3 or 9 o'clock. We put all patients on steroids, which is really important, 4 times a day, because the next day their eye can be somewhat inflamed, and doing indirect laser with an inflamed eye can be challenging. But if you give them steroid drops, their eyes are quite comfortable and they can tolerate the laser very well. So Roxanne and I are just going to show you some very simple cases here that we've done, just to give you an example of the basic types of cases.
Yeah, so no clinical specifics here. We have cases for later. It's just to illustrate the sequence of events. This is an example of a cryopneumatic. It all starts with knowing what you're dealing with, a very detailed retinal examination, attention to detail. Indirect laser to all pathology in flat retina. There's a little bit of lattice there. In this case, a cryopneumatic, cryo to the break in detached retina, AC tap and gas injection, positioning the bubble for 5 to 7 days. This is the patient the day after cryopneumatic retinopexy. This is day 12. You can see the laser to the lattice. You can see the cryo uptake vaguely in the vicinity of the primary break. And then normal activities can resume on day 12 or so when the gas is resorbed. And Rajiv has an example of a pneumatic with lasers, the other way to do it.
Yeah, so here's a two-step procedure where you have a superior break, bullous detachment, inferior lattice. We apply the laser. Again, the scleral depressed examination is the critical piece to prevent a lot of failures by knowing the pathology you're dealing with. We apply that laser to the inferior lattice, and then we proceed with our anterior chamber tap and gas injection. We then position the patient. So here you can see the laser. This was on day 1, almost fully attached with the gas bubble there in place. And we did indirect laser. And here you can see at 2 weeks the gas is gone with good laser around the retinal break, and the patient can resume normal activity. So now I'm going to actually jump right into